Hello, everyone. My name's Andrea DeBarber, and I oversee a laboratory at Oregon Health and Science University performing biochemical clinical diagnostic testing for CTX. And many thanks to Hunter's Hope for allowing me to come today and talk about CTX. I'm going to provide an update on newborn screening efforts for CTX. And this is a team effort. It's supported by multiple stakeholders, including patient advocacy groups, shown here. Here's my conflict of interest statement. And so, as most of you know, CTX is a progressive neurological disease caused by biallelic pathogenic variants in CYP27A1, encoding the sterol 27 hydroxylase enzyme that plays a crucial role in bile acid synthesis. And deficiency of this enzyme leads to bile acid deficiency and accumulation of the biomarkers cholestanol and bile alcohols that together are thought to account for the clinical signs and symptoms of CTX. Which may include in infancy and childhood neonatal jaundice or cholestasis that can be very severe and can progress to fatal liver disease. Also chronic diarrhea, which can impede growth, developmental delay, intellectual disability, and these all can present in childhood, juvenile cataracts, seizures, and then later in the course of this progressive disease, tendon xanthomas, psychiatric symptoms, peripheral neuropathy, cerebellar ataxia, spastic paraparesis, and cognitive decline and dementia later in the disease. So we think CTX is severely underdiagnosed and there is late diagnosis. So the observed incidence is much less than predicted by the CYP27A1 carrier frequency. Without newborn screening, the typical age of diagnosis is between 25 to 41 years old. But those diagnosed with CTX often wait more than 10 to 20 years after the initial symptoms onset in infancy and childhood, resulting in a significant burden of often irreversible neurological disease by the time of diagnosis. So tools to mitigate under and late diagnosis include a greater disease awareness in healthcare providers, genetic testing, biochemical testing, and newborn screening. And so I just have a slide here on the diagnosis in CTX. So after a positive newborn screen, a diagnosis of CTX would be confirmed with biochemical and/or genetic testing. So as I mentioned, genetic testing is biallelic pathogenic or likely pathogenic variants alone in CYP27A1. Confirmatory. However, if genetic testing is indeterminate, then biochemical testing alone would provide a confirmation of diagnosis. So as I mentioned, biochemical testing is measurement of cholestanol and bile alcohols that are derived from elevated bile acid precursors in the bile acid pathway. This testing is clinically available, and elevation of these biomarkers provides a confirmation of diagnosis. And we're finding out more about the disease and cholestanol, which has been used as the main biomarker for CTX for the last 50 years or so, may not always be elevated in some cases. So an affected newborn may present with diarrhea and or jaundice that can progress to liver disease, or no signs of symptoms of CTX may be apparent at birth. Either way, a positive newborn screen along with biallelic pathogenic variants in CYP27A1 and or elevated biomarkers establishes the diagnosis of CTX in the newborn period. So I just have a couple of slides on the bile acid pathway in CTX. So this is the classic or neutral bile acid pathway to the primary bile acids, cholic acid and chenodeoxycholic acid. These are formed in a pathway from cholesterol, which is initiated by the 7-alpha hydroxylation of cholesterol by CYP7A1. And so chenodeoxycholic acid and cholic acid normally act as ligands to activate the FXR, the farnesoid X receptor, providing an inhibitory cascade resulting in loss of activation of CYP7A1, so a decrease in the 7-alpha hydroxylation of cholesterol to start that pathway. When CDCA is deficient in CTX, CYP7A1 is highly activated. See these arrows in red. And so consequently, the synthesis of bile acid precursors and the derived cholestanol and the bile alcohols is greatly increased in CTX. See the arrows in blue. The biomarker that's used for newborn screening is the biotetrol, one of the biotetrol species that's present in blood. And so this is a glucuronidated species that we call GLIC-A tetrol, and it's glucuronidated at the and multiply hydroxylated with 4 hydroxy groups, including at the 25 position. And Dr. Orsini mentioned the treatment in CTX. So the treatment in CTX is just replacing the bile acid that's deficient in CTX, which is predominantly chenodeoxycholic acid. And this shut down the high activity of CYP7, works to shut down the high activity of CYP7A1, and then decreases the accumulation of all these biomarkers that accumulate in CTX, which are thought to be associated with the signs and symptoms of CTX. And so I'll talk more about the treatment this afternoon, but it's been used for the last 40 years or so since a landmark clinical trial in the early 80s for treatment of CTX, and it was approved then for the treatment of gallstones, and it's been used off-label since then. So we'll discuss that this afternoon. So in terms of newborn screening for CTX, there are MSMS methods to screen newborn dried blood spots for CTX that have been described and successfully further tested. So from Fred Vaz's lab in the Netherlands, a single-step screening algorithm has been described using negative mode flow injection analysis, MSMS analysis of the biotetroglucuronide species, biosalt species, and the use of metabolite ratios to decrease the false positive rate of dried blood spot screening to 0 in 217. And then he followed that up by a larger follow-up study screening 20,000 de-identified newborn dried blood spots using FIA, MSMS, or UPLC MSMS to determine metabolite ratios, and showed a false positive rate for this methodology of 0 in 20,000. My lab in 2018 showed that UPLC MSMS measurement of the GLIC-A tetrol species as a direct CTX marker to screen newborn dried blood spots for CTX worked. So we identified 4 high GLIC tetrol concentration dried blood spots. 1 dried blood spot was from a CTX carrier newborn, and 3 dried blood spots were from newborns with CTX that were identified. Additional use of either the metabolite ratio that Fred Vaz uses of GLIC tetrol over the Toro chenodeoxycholic acid conjugate, or genotyping, or a TC-DCA multiple of the median value effectively screened out the carrier dried blood spot, providing an overall false positive rate of 0 for this study. And then from Mike Gelb's lab in 2020, a large-scale screening study screening 32,000 de-identified newborn dried blood spots using UPLC MSMS measurement of GLIC-A tetrol again provided a positive rate of 6 in 32,000 with a cutoff of 500 nanomolar for this species. And further applying a cutoff multiple of the median value for TC-DCA left a single newborn dried blood spot result. Genotype analysis confirmed heterozygous pathogenic variants in CYP27A1 for this sample, and therefore the false positive rate from this study is 0 in 32,000. So in summary, the UPLC MSMS 2-part screening algorithm is effective to screen for CTX. The first part identifies any newborn with a dried blood spot concentration of GLIC tetrol greater than 100 nanomolar. The second part of the algorithm calculates either the GLIC tetrol TC-DCA metabolite ratio or the multiple of the mean from the primary bile acid CDCA as its taurine conjugate TC-DCA. Any newborn dried blood spot with a GLIC tetrol greater than 100 nanomolar and a TC-DCA multiple of the median value over a certain cutoff is designated as screen positive for CTX. As well as providing a positive result for CTX newborn dried blood spots identified in a large screening study, which was Mike's study, 10 out of 10 additional newborn dried blood spots that we've been able to obtain were positive, including samples with the lowest GLIC-A tetrol concentrations that we've observed to date. So in addition to the studies of the de-identified dried blood spots, the Screen Plus program, a consented and identifiable multi-disorder prospective newborn screening initiative in New York State, as Dr. Orsini spoke about, has further validated the UPLC MSMS approach using the two-part screening algorithm, first measuring A tetral as a direct CTX marker, and then screening the samples with a cutoff for TC-DCA. So early in implementation of the Screen Plus program, a newborn was flagged prenatally with possible CTX, and the dried blood spots from this newborn was subsequently and independently detected as a positive screen with a high A tetral result, and the TC-DCA multiple of the median value for this sample was also low. The newborn CTX patient identified in the Screen Plus study went on to receive a clinical and genetic diagnosis of CTX, and CDCA treatment was initiated. This program has adopted a cutoff for the A tetral of greater than 100 nanomolar. And this value was adopted based on a value for the lowest concentration CTX newborn dried blood spot from my lab that we identified. And this was stored by the California Newborn Screening Lab for more than 2 decades. And so we provided this to Dr. Orsini's lab, and he based the cutoff from this very low concentration sample. The TC-DCA multiple of the median value from this sample was very low again. So using this concentration as an initial screen has resulted in the New York State lab in 85 positives out of around 27,000 samples screened so far. Of these samples with A tetral greater than 100 nanomolar identified in the Screen Plus study, only 5 samples had a TC-DCA multiple of the mean value less than the cutoff, one of which was the confirmed positive CTX newborn sample. So the false positive rate for the Screen Plus study is 5 in around 27,000. So this is certainly an acceptably low false positive rate for newborn screening. So newborns that test positive with this two-part screening algorithm can receive genotype analysis of CYP27A1 and clinically available testing for other biomarkers for CTX, either as part of a newborn screening or during post-newborn screening follow-up. So the UPLC MSMS assay performance demonstrated for the Screen Plus program, as Dr. Orsini mentioned, will allow expansion, hopefully, of newborn screening for CTX to New York State, hopefully this year. So in summary, these approaches that I have mentioned have demonstrated excellent performance. Data obtained so far for 80,000 newborn dried blood spots screened has shown an extremely low rate of false positives, 5 in almost 80,000 newborn dried blood spots screened, including no false positive results for carriers. So while long-term data on false negatives will require years or even decades of population-level screening to generate, current evidence suggests that false negatives are unlikely, as the 2 CTX newborn dried blood spots identified in the screening study so far, and the 10 newborn dried blood spots obtained from known CTX patients that my lab has screened have all exhibited a concentration of A tetral greater than 100 nanomolar, and a TC-DCA value below the multiple of the mean value. So here is a timeline of where we're at this point. In 2021, I wanted to mention the CTX Alliance, a patient advocacy group dedicated to CTX that was incorporated in 2021. In 2022, the CTX Alliance supported efforts of the CTX Newborn Screening Task Force, which began their work on submitting a RUSP nomination for CTX. In 2022, newborn screened for CTX as part of the Screen Plus pilot identified prospectively a CTX newborn, allowing us to submit the RUSP nomination. Also, as I said, there are many stakeholders involved in these efforts. Hunter's Hope is supporting CTX clinical care guidelines with a focus on newborns that will hopefully be identified through newborn screening. And hopefully will become the first state this year to actually start screening newborns for CTX. And we were in pretty good shape here almost to submit the RUSP nomination for CTX. But as everyone knows, in March, the Secretary's Advisory Committee was disbanded. So where do we go from here? So the CTX, as I said, has brought together these global leaders in the field, the CTX Newborn Screening Task Force, and we will continue our efforts. We will pivot with loss of the advisory committee to focus on state level advocacy. We'll continue federal engagement in parallel. Hopefully there'll be an alternative to the Secretary's Advisory Committee. And CTX Alliance has come up with state-level action plans, mobilization and education of CTX patients and families, and long-term strategies, hopefully, that we can still move forward with advocating for newborns screening for CTX. And we will continue our efforts. And here I show patient advocates that went and presented to the Secretary's Advisory Committee back in 2018 when we submitted our first RUSP nomination. And at that time, we had not prospectively identified a CTX newborn to meet their N of 1 rule. So we have this now. And so this is where we are at in our efforts towards newborn screening for CTX.